Okay, I'm recording from an excerpt from 100 Strong Residency Interview Questions, Answers, and Rationales, a book that Brandon Dyson from TLDR Pharmacy and Tony Guerra from memorizingpharmacology.com just put out in ebook right now. But this script is to help those that are auditioning for the narrator position. I don't have a radio voice, and I'm wanting some kind of distinction between the narrator who asks the questions and makes the commentary, and then the interviewee. And a good narrator can make two voices that would make that pretty distinct, but also very interesting. But what I want to do is just do a reading so that the pronunciation is there, just to give a heads up to those that are thinking about auditioning for the part. Number 43, the Pharm 5, Part 3, same prefix. What are ceftaroline, cefepime, cephalexin, cefuroxime, and ceftriaxone for? This list question hits you with similar prefixes, so they're expecting you know these as cephalosporin antibiotics. Now, they are asking what happens as you move up the generations. This question works with antipsychotics, antihistamines, beta blockers, and so on. They're not expecting you to know the exact coverage, but that you can order them by generation and give the general trend. Here's how you might answer using the mnemonics from Memorizing Pharmacology. I'd first order these from first to the fifth generation, starting with cephalexin, then cefuroxime, ceftriaxone, cefepime, and ceftaroline. I remember ceph as the first generation because it has the archaic ceph, C-E-P-H. I remember the OX, ox, in cefuroxime to remember the second generation with two letters. The tri, T-R-I, for ceftriaxone, third generation. The four letters pime, P-I-M-E, for cefepime. And the five-letter tarol, T-A-R-O-L, for ceftaroline, the fifth generation. In general, gram-negative coverage, beta-lactamase resistance, and CSF penetration improves as you go up the generations. In Memorizing Pharmacology, you would also learn about the antipsychotics, which reduce EPS but increase metabolic effects from the first to the second generation. The antihistamines reduce sedation as you go up the generations. The beta blockers increase beta selectivity from first to second and add a vasodilating component from second to third. Ironically, retail pharmacy students tend to have a larger memorized drug formulary because most hospitals have a formulary limiting the student's exposure to their top 200 drug classes. Number 44, the Pharm 5, Part 4, different suffixes. What are lisinopril, valsartan, metoprolol, verapamil, and furosemide for? Now you have different suffixes, but in the same general pathophysiologic state. You may have heard that the ABCD mnemonic for cardiac drugs, A for ACEIs, ARBs, and alpha blockers, B for beta blockers, C for calcium channel blockers, and D for diuretics. You can add a little note about each, showing that you know where these drugs fit into the individual classes. Here's how you might answer using some help from Memorizing Pharmacology mnemonics. Lisinopril has the pril, P-R-I-L ending. That's an angiotensin converting enzyme inhibitor, or ACEI. Valsartan, the ARB, is an angiotensin II receptor blocker. Both of those are in the renin-angiotensin-aldosterone system, RAS, so I'd be concerned about that duplication. Metoprolol with the alol, O-L-O-L, ending is a second-generation beta blocker. A good choice if the patient had an asthmatic component, avoiding beta-2 blockade. The calcium channel blocker verapamil is a non-dihydropyridine that vasodilates and affects the heart, so there might be some overlap with the beta blocker, which is a concern. Furosemide is a loop diuretic which can deplete potassium, so I'd want to watch for that. While it seems like a challenging and somewhat comprehensive coverage, as a fourth-year pharmacy student in February, this should really roll off your tongue. 45. How do you approach an unneeded medication in med rec? If the interviewer doesn't have an example, it would be good for you to offer one like this. I've seen patients on Docusate sodium and Senna come to the hospital, yet they have no GI complaints. I find that in their record they had a past injury, were treated with opioids, but the anti-constipation medications were never discontinued. I'd work with the patient and provider to make sure they don't need these medications anymore. So a patient might have acute pneumonia treatment like levofloxacin, then that medication remain on their med list even 3 months later. So the team might restart the patient on levofloxacin unnecessarily and incorrectly. Be familiar with the pitfalls that come with MedRec, as there are often some common themes. There's an excellent TLDRpharmacy.com post aptly named How to Do a Medication Reconciliation.